Bueno, buenas tardes a todos. Espero que el calor no les esté dando una disminución en el rendimiento cognitivo. Y vamos a pasar a este simposium que estamos muy contentos de presentarlo porque tenemos datos muy interesantes que compartirles, evidencia científica muy sólida que se ha generado en la última década. Y para ello, pues tenemos un gran invitado que además hizo un viaje muy largo porque él viene desde Düsseldorf, entonces fue un largo viaje y está muy contento de estar aquí con nosotros. Y para ello démosle la bienvenida al doctor Peter Hartung, quien es neurólogo, neuroinmunólogo, ha dedicado toda su vida profesional de las neurociencias a la investigación de la fisiopatología y de tratamientos dentro de la esclerosis múltiple y el espectro de neuromielitis óptica. Entonces, démosle un fuerte abrazo al doctor Peter y adelante. Peter, welcome.
Thank you very much, Carlos, for the kind introduction. Estimados amigos, estimados colegas, it's a great pleasure and honor indeed to again attend and speak at your Congress. I'm really very fond follower of MACTRIMS, and it's great to be back in this beautiful country. So this is the topic that I would like to discuss over the next 60, 90 minutes or so. I will start off by reminding us of the astounding development of therapies for multiple sclerosis, and with reference to the high efficacy B-cell depleting therapies, I will just briefly remind ourselves of what we learned ex posteriori about the crucial role of B lymphocytes in driving the disease process of multiple sclerosis. With this as background, I'd like then to review the 10+ years of experience we've gathered with the first available anti-CD20 monoclonal antibody, ocrelizumab. And I will point out efficacy data, safety data. We'll talk about pregnancy and hope to just provide a relatively comprehensive overview of this very useful addition to our therapeutic arsenal. This is a slide, renditions of which you've seen before, just again pointing out where we started in 1993 with the baseline injectables, beta interferons and glutathione acetate, and then within a short sequence, a number of both parentally administered and oral drugs have become available and enlarged gratifyingly our therapeutic armamentarium. And as I mentioned, we've learned, or we have sort of rediscovered and then investigated in more detail the fundamental role that B cells play in MS pathogenesis. Of course, prior to the introduction of the monoclonal B cell depleting antibodies, we traditionally considered B cells as the source of demyelinating autoantibodies. Now, this view, based on a number of observations, has changed, and one certainly was the speed by which B-cell depleting agents kick in their efficacy. This would not be consistent with a major role of them decreasing autoantibody production by B cells. So more recently, we think that B cells have a fundamental role in initiating the aberrant immune responses of MS, and this includes their capacity to present antigen to T cells, to activate them, to proliferate and manufacture pro-inflammatory cytokines, driving autoreactive T cells into the CNS, activate their microglia, orchestrate a trialogue of B cells, T cells, and microglia, produce and release a toxic factor that causes oligodendrocyte death, and as we learned over the past years, and this is quite significant in our understanding of the progressive phase of the disease, that they set up subpeel aggregates, compartmentalize inflammation secluded from the general immune system, and apparently drive smoldering disease and progression. So B cells in MS have been identified as a target of immune intervention. We will focus on the anti-CD20 monoclonal antibodies, but perhaps BTK inhibitors, we'll see, may also play a role at the most recent development, the use of CAR T cells, chimeric antigen receptor carrying T cells directed to CD19. So B cells produced as stem cells in the bone marrow then develop in the periphery into pro-B cells, pre-B cells, immature, naive B cells. Then they take a habitat in various organs of the immune system, such as the spleen, lymph nodes, plasma cells, and mature naive B cells would then transform into memory B cells, and they may then also reside not only in the periphery, but importantly in the central nervous system. And there they, again, as I mentioned earlier, interact with both T cells and microglia, myeloid cells in the central nervous system to drive the pathogenic process within these meningeal follicles, which are not made up by B cells alone, but they represent really a mini replica of the immune system. So their B cells can also interact with other cells to drive the pathogenic process. Now, you all know that B cells have a specific lineage, and that each and every distinct stage can be identified by their display of surface antigens like CD20, CD19, and so on. And you all know that CD20 is carried by pre-B cells to memory B cells, so leaving the most proximal and the most distant part of the B cell lineage intact. This is very important when we administer monoclonal antibodies that deplete this certain specific part of the B cell lineage, because defense mechanisms remain intact. Both new stem cells can turn into pre-B cells, and the collective immunologic memory carried by the plasma cells in the periphery are there to fence off any invading microorganism. Now, anti-CD20 monoclonal antibodies are not just one class. We have to realize that they have been engineered to recognize different stretches, molecular stretches on the CD20 molecules. And this is depicted on the right panel, where you see different epitopes recognized by the different anti-CD20 monoclonals. How that translates into different modes of action, clinical efficacy, we don't know. It may be relevant in terms of what one can use to very deeply deplete B cells, not just in the periphery, in blood, but also in immune organs. And of course, we know from the clinical trials that the route of administration, the therapeutic dosing regimen differ. So let's, in the rest of my talk, then focus on ocrelizumab, which was the first anti-CD20 approved, both for relapsing, remitting, and at least in some geographies, also for primary progressive multiple sclerosis. So these are the pivotal trials that were published some 7 years ago, the OPERA 1 and 2 twin trials in relapsing MS and the Oratorio trial in progressive MS, and of note, the first drug ever shown to be efficacious in primary progressive multiple sclerosis. So I think it's worthwhile, although it's a truism, that the primary goal of our treatment efforts is to prevent disability. Well, we need to cut relapses, these bursts of inflammatory activity, but importantly, the long term is dictated by the accumulation of disability resulting in various shortcomings of functionality in the patients. And the past 5 years have seen a sort of shaping of what we understand by worsening and what we notice both in clinical practice and in trials. And you're all familiar with the two ways disability accumulates. That's the classical way, relapse associated, or also referred to as RAW, where disability results from incomplete recovery from a relapse, and PIRA, progression independent of relapse activity. So that escapes our attention when we do not specifically interrogate patients and their disease cause for it. Now, applying these definitions, the OPERA trials demonstrated that over 75% of disability worsening was independent of relapse. So this also tells us it's definitely not sufficient for us to just focus when we see a patient on whether he or she has a relapse. There is disease ongoing and disability accumulating independent of relapses. And it's just a matter of how closely and how granularly we look at the patient's course. And of course, a number of instruments are available and are becoming available that will aid us in this approach. Now, you all know that disability is mostly irreversible, but may be preventable. It's again now almost a truism to say that it's mandatory to take early action in order for the progressive disability to evolve over time. And this is just one piece of data amongst many others to show that there is a unique window of opportunity for treatment, and particularly for high efficacy treatment, because people with MS will never later on catch up. This is a slide demonstrating the cumulative hazard of confirmed disability progression in relapsing patients treated early versus late with high efficacy therapy. And you can see that if you initiate the high efficacy treatment from the onset, there is a significantly reduced risk of accumulating disability when compared to a later initiation of high-efficacy therapy. Looking at it in a different way, these are data obtained in the OPERA 1 and 2 trials in relapsing, in oratory, and primary progressive MS. And you see that with ocrelizumab, you delay the occurrence of disease progression by almost 10 years. I think that is very impressive. Again, we've recently reviewed the evidence gathered from open-label extension of pivotal trials, observational studies, real-world experience, and national and international registries to make the case, like others, that it's really time for early treatment with high-efficacy drugs. Now, I briefly mentioned that we need additional instruments that aid us in this particular instance in the prognostic approach, which patients are destined to develop disability accumulation early on and whom we could specifically target with high efficacy treatments. And there are a number of things emerging, such as the fluid phase biomarker, gliofibrillary acidic protein, that has been shown to be associated in level with a risk of 6-month confirmed disability progression. And in terms of imaging, the slowly expanding lesions, where it was shown that the proportion of them at baseline is linked with a higher risk of 9-year EDSS score worsening. So let us review in short the impact of a decade of ocrelizumab use in preventing disability and multiple sclerosis. You may remember, those of you who attended ECTRIMS in Milan last year, that then and later at this year's AAN, the 10-year experience was presented for both the OPERA and oratorio studies. And as an executive summary, one can say that Ocrevus is the only anti-CD20 approved for the treatment of both relapsing and primary progressive MS, with more than 10 years of clinical experience and now over 350,000 patients treated globally. Just to re-emphasize the goals of these studies that were presented in Milan and in Denver, having in mind that it's the cardinal goal for us to prevent or slow down disability evolution. And let's first look at the data in relapsing MS. And here the trial data, the OPERA trial data, were interrogated. Here you see the proportion of patients that did not develop confirmed disability progression over time. The blue line representing patients that from the initiation were receiving ocrelizumab, whereas the yellow is representative of those that had initially in the control phase interferon beta and were then switched to ocrelizumab. Now, after 10 years, most patients did not experience disability accumulation, 8 out of 10, with continuous ocrelizumab treatment. Patients who initiated ocrelizumab early maintained the benefit compared with patients who switched after just 2 years. Now, if we look at a critical benchmark in disability evolution, the requirement to need a walking aid, again, the superiority of ocrelizumab was demonstrated, over 10 years, there was a 42% in the risk of requiring a walking aid in those who initiated ocrelizumab earlier. So 91.9% of those patients that had received ocrelizumab from the beginning did not require a walking aid at 10 years. Now, of course, it's very important to look at the pathobiology and the impact of a treatment by imaging. And just as one example of many looks that were taken at these populations, the continued and significant reduction of T1 GAD-enhancing lesions, a reflection of the inflammatory activity over time. You see it here over 10 years, the initial effects in the randomized controlled trial. The significant diminution versus the active comparator was maintained into year 10. And similarly, T2 lesions representative of disease burden had a very low value maintained over 10 years. Brain volume loss, of course, is very important. This is one recently published study from a subgroup of patients that were enrolled in OPERA 1 and 2, but I should say that the look at the entire population where data were available are aligned with those quite nicely. So whole brain, white matter, cortical gray matter, thalamic cerebellar volume loss was assessed in 44 healthy controls, age-matched, and 59 patients with RMS. The volume loss rates were close to those of age-matched healthy controls. If you look at the right-hand side, there was basically no significant difference. So ocrelizumab prevented the brain volume loss, which we know is accelerated in MS, and brings them the rates to the level seen in the healthy aging population. Another important biomarker way about you read each and every week, I mean, there are now probably hundreds or thousands of papers looking both at MS but also other neurological diseases, is a fluid phase biomarker of neuroaxonal damage and has been examined in patients undergoing treatment. And you see here the data from the relapsing and primary progressive trials where the violet line represents the patients randomized to interferon beta 1a, and the bluish lines the ocrelizumab patients, and you can I think easily see that within a short period of time the elevated levels come down in response to ocrelizumab, again sort of building the argument that ocrelizumab targets both the inflammatory and neurodestructive processes going on in multiple sclerosis. Let's now have a look at progressive MS. Again, as I mentioned, here ocrelizumab is currently the one and only drug that has shown some efficacy. Here, similarly to what I showed you earlier, is depicted the proportion of patients without confirmed disability worsening. And in this group of patients, the ones that received ocrelizumab early maintained the benefit compared to patients that were switched after 3 years. And this ended in the effect that 1 in 3 of those patients were progression-free after 10 years. And after 10 years, 8 of 10 patients with progressive MS treated continuously with ocrelizumab did not require a wheelchair. It's also very important to look at tolerability, of course, of treatment long-term with any drug, and particularly in this instance with ocrelizumab. This is from the OPERA trial, the 10-year follow-up. 52% of patients initially randomized adhered to and completed this 10-year open-label extension period. This is quite significant, and very similar percentages have been noted in the oratorio extension trial. Now, with any kind of drug that impacts the immune system, questions arise about safety, particularly as regards infections and malignancies. In the case of B-cell depleting agents, of course, the question is there hypogammaglobulinemia, which you would expect to occur? Is this associated with serious infections? In terms of malignancies, which are due to compromised immune surveillance, of course, some initial studies raised some concerns, but the 10-year plus now experience, and very particularly the comparison with background incidence of malignancies is really reassuring for ocrelizumab. Again, I think it's important with all these considerations to account for background incidence, both in the untreated MS population and in the general population. Now, 11 controlled trials covering the entire spectrum of MS have been carried out with ocrelizumab, close to 4,400 relapsing patients. And they have been studied for the development of hypogammaglobulinemia, or I should be more precise, because hypogammaglobulinemia is a hematological diagnosis. Here I'm referring to lowered IgG or IgM levels. The pooled experience showed 241 serious infections when IgG was above the lower limit of normal, 20 serious infections when it was below the lower limit of normal. There was no real consistent pattern identified as regards the infections encountered, and all serious infections associated with low IgG recovered. There were no fatal outcomes that could be treated. Now, on the right-hand side, you see that out of close to 2,100 patients, 9.5%, some 200 patients had lowered IgG levels below the lower limit of normal. Only 15 patients, translating into 0.7%, with these lowered IgG levels had serious infections. So a very minute proportion of the entire population. This is to show you over a period of 8 years the incidence of serious infections in patients with ocrelizumab, both in relapsing and primary progressive MS. There was a blip with COVID-19 during the pandemic, but basically the incidence over time remained very stable and low. Again, important to note is the relationship between covariates and infections in relapsing MS patients. This is 11,400 patient years of exposure and experience, and it turned out that a higher BMI above 25, comorbidities, and a higher EDSS are associated with a higher risk of infections under ocrelizumab therapy. Now, what are those serious infections? Look at the breakdown. There were, in the majority, 312 bacterial infections, and of note, most of them were treated with just standard antibiotics and made a full recovery. Also important, there were no de novo cases of hepatitis B infection, no HBV reactivation. Herpes virus-associated infections that we all know were very uncommon, all resolved. CNS serious infections in terms of meningitis encephalitis were very uncommon, and importantly, there was no evidence for the occurrence of opportunistic infections, PML, cryptococcosis, aspergillosis, and so on. So that's reassuring. The executive summary then, and please remember that I sort of loosely, and many others, refer to lowered Ig levels as to hypogammaglobulinemia, but the hematologists insist that a number of criteria have to be fulfilled, that this is a disease in its own right. So what we learned from the experience with ocrelizumab, that only a small number of patients is expected to have IgG and IgM below the lower limit of normal. Importantly, these lower levels were not associated with, statistically, with serious infections in either population. Conversely, cofactors such as having more than 2 comorbidities, a BMI above 25 and EDSS in the upper range, were significantly associated with an elevated risk of serious infection. Also important to know is longer treatment duration was not associated with higher risk of SI. So coming to the summary of the data reviewed, and of course there's many more available. Over 10 years of continuous ocrelizumab treatment, the overall safety profile remained consistent. I think that's a very important message, particularly also that there was only a low incidence of serious infections, and the cumulative standardized incidence rates of all malignancies, and particularly of concern, female breast cancers, remained within the range reported in real-world registries. And adverse events leading to treatment discontinuation remained infrequent and was not driven by serious infections. So ocrelizumab continues to exhibit a stable and favorable safety profile. Now let's have a look at some special populations that have been examined following approval of the drug. And this is one example, the Ensemble study, an open label single-arm study. The design of it you see displayed here with the traditional endpoints also used in the pivotal trial and some additional endpoints. A patient population shown on the left-hand side, which was treatment naive, so representing in all regards a very early stage MS population. And what this study basically showed, it was in accord with the results obtained in the pivotal trial. And if one looks at no evidence of disease progression, some 66% did not develop confirmed disability progression. You see the split down in the various components, 22 weeks confirmed disability progression, then timed foot walking, and upper extremity dexterity assessed by 9-hole peg test. And importantly, the great majority of patients had a stable EDSS, some 23% improved and 18% worsened. A very interesting observation was presented from the Italian MS registry last year in Milano, when, amongst other high-efficacy drugs, allogeneic hematopoietic stem cell transplantation, which in the past has shown to be very effective, although with some inconsistency in the results, demonstrated no major difference in terms of disability worsening or improvement when compared to ocrelizumab. And this, I think, is a very interesting result that needs, of course, to be fully studied and replicated. On the other hand, I think most of you would agree that hematopoietic stem cell transplantation is a more invasive, or is an invasive procedure still associated with morbidity and, fortunately, lesser mortality these days. But you have to obviously realize the ease of administration of the drug versus this procedure. Now, the final bit will relate to the role of anti-CD20 therapies in general and ocrelizumab, in particular in pregnancy and breastfeeding, in a population that is overrepresented amongst the MS population. This is from a review by Ruth Dobson and colleagues looking at more than 1,200 pregnancies, and the full report is not available. There were in females where ocrelizumab was used within 3 months of conception, 171 live births, 20 elective terminations, 29 miscarriages, 4 stillbirths, and 2 ectopic pregnancies. Now, the ongoing registry of female patients undergoing pregnancy whilst on ocrelizumab has interestingly shown that over the past couple of years there has been a significant increase in the total number of pregnancies reported with ocrelizumab. Looking at it's 4,000 patients. It was shown that most pregnancies resulted in live births. You can compare the non-exposed, exposed, unknown total population and the epidemiological rates to put it in perspective. Most live births were full term. So I think very, again, reassuring for the patients that are in the reproductive stage. And I'd like to draw your attention to 2 ongoing controlled prospective trials, the largest hitherto conducted with Ocrevus, the Minori and Sopranino studies in women with MS and their infants, and interim results analysis will be presented at the upcoming ECTRIMS. My conclusions then: a decade of ocrelizumab use has shown that some 80% who received this drug earlier showed no signs of disability progression. 92% of patients relapsing MS who received Ocrevus early on did not need a walking aid. More than 10 years of continuous exposure to ocrelizumab was not associated with any new or unexpected untoward effects or safety signals. And as I mentioned, there are now some 350,000+ patients worldwide who receive ocrelizumab. Before ending, I'd like to draw your attention to the next European Charcot meeting in Baveno, which will be devoted to a critical assessment of changes in MS that have occurred in the past 25 years and the impact that treatments have made. So it would be nice if you had the chance to join us, hopefully in person, but otherwise virtually. And with this, I'd like to thank you very much for your attention.
Vielen Dank, Peter. Hervorragende presentación. Bueno, buen provecho a todos. Si tienen alguna pregunta, recuerden que lo pueden hacer por la aplicación o hay micrófonos en el centro del pasillo donde pueden hacer preguntas directamente. Lo pueden hacer en español. El doctor tiene un traductor en vivo. Entonces, no sé si hay alguna duda, alguna pregunta para el doctor Peter. ¿No? ¿Nadie? Ah. Adelante, Eli.
Muchas gracias, doctor, por su presentación. A mí sí me ha tocado casos de pacientes con comorbilidades, pero con niveles bajos de inmunoglobulina, con infecciones que han requerido hospitalización, neumonías o sepsis urinarias. ¿Existe o en su experiencia algún parámetro o indicación para administrar inmunoglobulina intravenosa o subcutánea en estos pacientes? O incluso pensar en modificar esquemas, alargar tiempo de dosificación o reducción de dosis de ocrelizumab. Gracias.
I'm afraid I think I didn't catch all the translations, so could somebody help me just...
Or I can tell you in English. Okay.
Thank you.
I've had patients with severe pneumonia or severe urinary tract infections which have required hospitalization. Those patients usually are elder or have comorbidities. But in your experience, do we need to reduce the dose, give extended doses regimens, or even give IVIG or subcutaneous immunoglobulin? Thank you.
Thank you very much for your questions, and apologies that I didn't understand it completely firsthand. These are very relevant questions that you bring up. From the data that were collected over 10 years, all serious infections recovered completely, and those that were bacterial in origin just required a straightforward approach. We've seen severe cases that you mentioned in elderly patients with an additional risk profile dictated by cardiovascular, diabetic, and so on and so forth. We also had to hospitalize them, and in some instances where we noted significantly lowered IgG or M levels, also used high-dose IVIG. And, you know, it's sort of anecdotal evidence, but we thought this hastened the recovery. So we didn't lose a patient in this patient group, and I understand that this is also the experience that was collected in this larger cohort.
Sorry, do you use any parameter of IgG levels to decide to give IVIG, or is there a...
Well, we have really made a case-by-case decision in patients with severe infections who were all amongst those very few, if you look at in the totality with the lowered Ig levels, but were then really guided by the severity of the clinical presentation. On the other hand, I think the data that I presented, the rarity of such a significant decrease in IgG and the lack of association with, by and large, I mean, there are always these exceptional cases, with a serious infection, in my mind, sort of should provide some reassurance that if for one reason you don't regularly check Ig levels, as long as nothing happens, this is okay. We personally would carry out yearly IgG, M, and A levels in any patients undergoing high efficacy immunointerventional treatment.
Thank you, Peter. We have a virtual question. Tenemos una pregunta virtual y es ¿cuántos años deben mantenerse como mínimo en tratamiento con ocrelizumab los pacientes? They are asking how many years must a patient be on treatment with ocrelizumab?
Well, I think we don't know this so far, as we don't have any curative therapies available. You may consider that it's a lifelong therapy. As patients age and with the phenomenon of immunosenescence setting in, they have also been studied with other drugs of the effect of discontinuing therapy, and some patients without risk factors may be safely discontinued. I don't think we have so far convincing evidence as regards the anti-CD20 monoclonal antibodies. Clearly, if you and the patient, I mean, it's a shared decision as always, decide, opt to discontinue, you have to very careful and rigorously monitor. And by the way, my colleagues had this question whether in these severe infections encountered on ocrelizumab, whether one would extend ocrelizumab dosing. Of course, this is an issue that has, or practice that has been brought into play in the pandemic. And there are a number of investigations, including one from our department, to show that stretching the interval does not necessarily sort of lessen the clinical efficacy. But to date, we need to, in general, comply with the label that the regulatory agencies have provided based on the results and the design of the pivotal trials. But again, as I said, when the pandemic occurred, for a number of reasons, the interval was extended, and there have been studies, also one from the Amsterdam MS Center, to show that there are certain ways that would help you to decide whether you could sort of dare to extend the interval without jeopardizing the clinical efficacy.
Thank you, Peter. We have another question here.
I'd like to ask you, have you studied neurophysiological side effects of your product in patients with who have been taking it for 3, 5, or 10 years? What are the side effects in the neurocognitive and the emotional side effects, please?
I think the relevant side effects that we have come to know haven't changed in incidence markedly when you look at 3, 5, or 10 years. So they stay sort of stable.
Sleep-wise, Have they affected the sleep?
I am not aware, maybe Dan could help. I'm not aware of specific studies, or maybe Carlos, you know?
No, I don't have any knowledge about it.
Well, certainly, like with a number of immunoactive drugs, you notice a lessening of fatigue. And I didn't have time to go into this issue, but I think I should mention it, and you're well aware the importance of PROs, patient-reported outcomes, that may more comprehensively reflect the impact the disease has on the patients in a way that we cannot assess clinically or by MRI. And as you know, the regulatory agents nowadays require the study of PROs when a dossier is submitted to them for approval. And there are a number of initiatives ongoing, and I think also speeded up by the pandemic. The use of digital monitoring has become very important as an add-on to monitor with greater granularity and depth the impact of a treatment on the patient.
Thank you, Peter. We have another question. No sé si hay alguien quiera hacer una pregunta en los micrófonos, si no, para seguir. ¿No? Ok. La otra pregunta dice, en pacientes con esclerosis múltiple y otras enfermedades autoinmunes como lupus o miastenia, ¿el uso de ocrelizumab ha tenido algún impacto en estas enfermedades? ¿Se ha obtenido algún beneficio concomitante que permita disminuir dosis de medicamentos de las otras enfermedades? So they are asking, Peter, that besides MS patients, is there any experience with ocrelizumab with less or myasthenia or other autoimmune diseases? And is there any beneficial effect on those patients that might permit that you lower other pharmacological therapies?
I'm not aware of published data of ocrelizumab in indications other than MS. You might, of course, anticipate that is as effective as other B-cell depleting agents. You know that, for example, rituximab has been used in myasthenia gravis, in CIDP, in the antibody-mediated encephalitides, in NMOSD. But again, I'm not aware of any published data on this.
Si me permiten, nada más para agregar, nosotros en Roche tenemos más de 4 anti-CD20s, diferentes tipos. Hay un biespecífico, diferentes potencias, diferentes características. Algo que es importante saber es que siempre nuestros pacientes van a ser individuales y hay que individualizar el tratamiento. Cada uno de estos anti-CD20s tienen diferentes características, es decir, no todos los anti-CD20s son lo mismo. Aunque vayan al mismo target, tienen diferentes epítopes y tienen diferentes grados de eficacia y seguridad. Ocrelizumab, previamente a esclerosis múltiple, fue investigada en lupus eritematoso sistémico, en síndrome antifosfolípido, en otros problemas autoinmunes y no demostró la suficiente eficacia. Entonces se fue buscando en dónde es donde tenía más eficacia y se vio que en esclerosis múltiple era la mejor opción. Adelante, Alberto, si quieres, aquí hay un micrófono.
Sí, muy buenas tardes. Doctor, muchas felicidades, muchas gracias por su magnífica conferencia. Como neurólogo general, después de escuchar esta plática con esta información, es realmente asombroso ver los resultados que ustedes están presentando. Y aquí la pregunta es, ¿existe algún estudio comparativo con algún otro fármaco donde se tenga el grado de inactividad de la enfermedad para tener un comparativo head-to-head de algún otro medicamento que no sean los interferones con lo que es el ocre? Gracias.
Well, I think, quite frankly, while it would be in many ways scientifically interesting to look at a comparison with more efficacious comparators in a controlled design, this is highly unlikely to occur. There is real-world evidence, for example, when you interrogate the international MS base for relative efficacy, and ocrelizumab always is in the top range when compared to other approved DMTs, but in all likelihood there won't be a controlled trial with other agents. You know, the more recent controlled trials using active controls utilize teriflunomide with sometimes interesting results.
Thank you, Peter. And last question. Nos preguntan también del público si existe alguna relación entre los niveles de inmunoglobulinas o CD20 con el fenómeno de fin de fase o de wearing off en los pacientes. They are asking if there is any relationship between IG levels or CD20 levels with the wearing off phenomena or the end of phase phenomena in patients with ocrelizumab.
Again, a very relevant question. There is, to my knowledge, no relationship with the IG levels. There is controversial evidence as regards the role of peripheral B cells, the CD19 B cells that had initially been used to gauge the necessity to repeat the next or give the next round of ocrelizumab. Probably one has to immunophenotype deeper, so looking at memory B cells, and I don't think that at the present time this is something of practical relevance or that should be incorporated outside scientific investigations into the management. That's my personal bias, I must say. Because initially we looked at the number of circulating CD19 cells and we saw everything. You know, we saw that patients stayed a year with very low levels, but the low levels didn't tell us necessarily whether we would have to reinstitute the therapy. So in short, my reading is no.
Vielen Dank, Peter. Muchas gracias y espero que hayan disfrutado. Un fuerte aplauso para el doctor Hartung y continúen disfrutando.